infections or the Storch's infections. What's the S? At what heart rate do you need to start chest compressions for a neonate? Less than 100. Or sorry, less than 60. I heard somebody say. I heard somebody say 100. I said less than 60. How do neonates respond to hypoxia? Apnea. Yep. When you're doing eyes and thighs, what is the eyes? What are you giving? And what are you giving erythromycin ointment for? Gonococcal. What is the thighs? Vitamin K. Hep B. Yep. We didn't do that. Caput succedaneum. Is it safe? Is it scary?
Safe.
Which is the scary one? You want me to give you options?
Yeah.
If I told you it was a cephalohematoma, is that a safe or scary one? What do you say? If I said subgaleal. That's the one, yeah. Yeah. Galeal, the G, go get help. Okay. On the quad screen, what does the quad screen look for? Trisomies, which ones? 13, 18, and 21. And what else? Alpha-fetoprotein, and that is looking for spina bifida. And if you're adding fetal sex on there, what's to George? What's it? Yes, the harmony. Yep.
Turners.
Okay, so we got it. You guys are doing great. So already you knew so many things about pediatrics, about the baby developing, about the baby being born, that immediate care, and we had started and done the head part of the examination. So we had gotten down to the eyes yesterday. So that's where we're going to pick up, and we're going to do the rest of the exam while y'all study nephrology. So in your eyes, when you are looking at the eyeballs and you take a picture and you get that red eye response, what is that red eye response actually? What is that? The retina. Yes, you're looking at the vascularized retina at the edge of that fundus, and so you're seeing that it is vascularized and the media is transparent, and so that's what's giving you that red hue back. So that's what the red reflex is. We want to make sure that the baby has a fully vascularized retina and that there is nothing impeding that. What things that could be impeding it? You think about a tumor, so an ocular tumor or a retinoblastoma could be impeding that media. You could also think that they can have an infantile cataract. That would be one of the things. Or you could have an entity called retinopathy of prematurity. So what's going on in this particular entity is that the baby does not have that fully vascularized retina. And we'll talk about that in a second, but all of these are going to go to ophthalmology. And it's very specific. If you send them to optometry cannot do anything surgical for this child. And all of these things are going to require a surgical intervention. So it is going to be an ophthalmology referral specifically to pediatrics for that. Let's talk a little bit more about this retinopathy of prematurity. And allow me to nerd out on you guys for a few minutes here. So in the babies in utero, we talked about this yesterday. What did I say was the typical oxygen concentration in utero
65?
for the babies? Yeah, upper 50s, low 60s, right? What we would consider cyanotic for us on the outside. Well, that low oxygen content actually is one of the things that stimulates a growth factor. If you go way back to biochem and you think about those growth factors, like VEGF. So VEGF is then this growth factor that because of the low oxygen environment, it's spread out across the retina, and that growth factor allows the retina to be vascularized. Pretty cool, huh? It's not cool when the baby is suddenly born early and they are taken out of that low oxygen environment where now for their brain, for their heart, and for their lungs, we're trying to get that oxygen as high as possible. The problem happens is now they don't have that low oxygen environment that allows their retina to continue to be vascularized. So it just stops. So you don't get that full vascularization of the retina. So we have a continual balance in the neonatal ICU to say let's keep the oxygen as low as possible to promote that vascularization and high enough that their brain, heart, and lungs can continue to function. That's fine, so we get it down, but once that process has been interrupted, oftentimes instead of growing out nice like it should towards the retina, it grows aberrantly and it will start to grow out and form a ridge. And that ridge then can end up pulling the retina, and that's how you can have an infant with a detached retina from that. So this is one that we follow very, very closely in the neonatal ICU to make sure that they're having continued vascularization, that we keep that oxygen not too high because it is very, very harmful to the eyes. A little bit of a tip for all of the things in my class. All of the words matter, right? So if I say retinopathy of prematurity, all three of those words matter. So prematurity being the primary factor. If that baby's not premature, don't pick that as an answer. It's not the correct one, okay? So this is for only premature infants whose retinas have not continued to vascularize. Another thing that happens, babies are in utero. It is dark there all the time, so they have not had any kind of light exposure. So the baby comes out, and their vision is anywhere from about 2200 to about 2400 when they first come out. So they're functionally, legally blind little guys when they first come out. They can see some light, they can see some faces. So they can make out, you know, this is my mom, or this is light, and I want to keep my eyes closed. But over the course of several months, as they're having that visual stimulation and those parts of the brain are kind of waking up and turning on, their eyes will start to crisp up. Their vision will start to rapidly improve. And so it will go from this 2200, 2400 up until something where they have eyes, you know, 2080 is roughly where they will end up. But while that process is happening, while their vision is so bad, you will get this completely normal phenomenon of this disconjugate gaze of the newborn. So if you've ever looked at a newborn and this newborn is staring back at you and one eye's over here and one eye's over here and they kind of have googly eyes, it's totally normal in the newborn baby. You should see that disappear by about 4 months old. So at that point they've had enough light and enough visual stimulation that their vision has improved or kind of crisped up enough that they are not having this disconjugate gaze anymore. So if they come for their newborn follow-up, they come for their 2-week-old infant well check, they come for their 2-month well check, and their eyes are googly, totally fine. They're there, their 6-month or their 9-month check, and they still have googly eyes, where do you think you're going to refer them? Ophthalmology, correct. Moving on from the eyes to the ears and the nose. So if we're looking at the nose, you do not know that both nostrils are open. So thing one for the exam would be to close one nostril, see if the baby continues to breathe. Close the other nostril, see if the baby continues to breathe. They are obligate nose breathers, meaning they will breathe through their nose because they need their mouth to feed. So they will breathe through their nose, so it will be very, very quick. If you occlude one nostril and they can't breathe, you know that it is not open. Second thing you're going to be looking for, is there any kind of cleft lip or cleft palate that is involving some of the nasal bone or nasal structure? That can be at the very back of the palate as well. So when we're checking some of the mouth things later on, making sure that there is no cleft palate way in the back. For the ears, so look over at your neighbor, look at their ears. What you're looking for is if you are going from the edge of the eye to the back part of the occipital protuberance, and if you drew a line between that, you should intersect the ear. That's where you should see. So if you are drawing that line right across, you should intersect the ear. If you draw that line from the tip of the eye to the occipital protuberance, and the ear is below that, that is considered low set ears. And you typically see that with increasing with congenital anomalies or some sort of genetic malformations. The other thing we'll look at is posteriorly rotated ears. So if you look at the angle of their mandible, in conjunction with where your tragus is, and the top of the ear, it should be no more than about 20 degrees. So if you see one that has more than that 20 degrees into that 30-degree range, you know that the ears are posteriorly rotated. Again, you see that in increasing amounts with congenital anomalies or genetic malformations. The other thing we'll see with the ears when we look for are little pits. So it literally looks like somebody took a little pin and made a little mark right there at the top of the ear, a sinus pit, or they will have little ear tags. The interesting thing about those, there's nothing really that I care about with pits or tags. Maybe a cosmetic issue if it's going to get caught on something. Maybe the little pit could get infected, but there's really nothing about the pit or the tag that innately makes me concerned. But what I start thinking about is, well, what other organ formed at the same time that the ears did that I can't see? And the answer to that would be that your kidney formed at the same time as your ears. So if something happened with the ears, and there's pits and tags, did something actually happen with the kidney at the same time, and do I need to do any further investigation for the kidney? Maybe not. Maybe it's a completely isolated finding of the ear, but it's something to think about on exam. If you see a pit or a tag, might have a lower threshold to get a kidney ultrasound. Your ears. So take your fingers, try to flip your ears over. You should have them snap back. Nobody should have, if you do that, the cartilage should snap back. No one should be able to keep their ears folded. That's not the case for a premature infant. So if you did that in a significantly premature infant, the cartilage would just stay folded like that. So the more elastic that you see, where it kind of springs back in that cartilage, the more term that this child is. You can see that the ear of a 26-weeker is going to stay folded like that. The ear of a 32-weeker not fully developed even with that cartilage, and then what a term ear is going to look like. Some of the things in the mouth. So besides checking for their cleft lip and cleft palate in the mouth, you're going to check for a couple of other things. So one of the ones we'll look at are either Epstein pearls or Bond's nodules. The easiest way to think about this is that have you ever done a house project and at the end you have a little, like a few 2x4s left over or little bits of scrap wood? It's kind of what happens in some of these instances. There's little bits of keratin left over that will be in these kind of white keratinized little balls that are either on the gums, on the lips, kind of inside the mouth, that go away over time. That's the way I think about it. It's kind of this leftover scrap wood, these leftover extra keratin that you will sometimes find in the gums or in the mouth on the salivary glands. Nothing you need to do, completely normal variant, and they will go away on their own. What you're trying to make sure is that it's really just an Epstein pearl, that it is not a natal tooth. If they have a natal tooth, they don't typically have a great root structure, and so we worry that is that tooth going to come out and they're going to swallow that or aspirate on that, choke on that tooth. So if you see a natal tooth, that would be something that you need to take out or have a pediatric dentist removed, because it's not only going to be relatively painful for mom, but it is an aspiration risk as well. Things with the neck. Babies don't have much of a neck, so if you look, it's kind of that egg on toothpicks kind of looking little baby with not much of a neck. So one of the things that we're looking at is when we're trying to find it, is there any kind of nodules or cysts? Is there bumps, lumps, anything that we're going to see there? And then looking to see anatomically, where is it? So if we see something midline, our midline organ that we think about is always our thyroid. Does it move when the baby swallows? Is it connected to the thyroid? Do I need to ultrasound that? Then my next anatomical location, if it's not central, is to locate their sternocleidomastoid and say, is it anterior to that or posterior to that? Anterior, depending on your embryologic origin, you're more likely to have some of your cysts and part of your brachial cleft cysts that are still remnants, versus posterior, you're more likely to have lymphatic issues. So that's an example of a cystic hygroma, would just be an example. So lymphatic malformations posterior versus anterior, more embryologic cysts that you would see. This is relatively uncommon, doesn't happen a whole lot though. We're moving down into the chest. So we're first looking to see, is there an alignment? So was birth really difficult and we had a clavicular fracture, where now we have an asymmetric chest? Are we seeing movement of both sides of the chest? Or during resuscitation, was there a pneumothorax on one side and only one side of the chest is even moving? You have that really big baby, that really gigantic, large for gestational baby. Those ones will sometimes come out after having shoulder dystocia, where their shoulder is truly caught inside the pelvis. They can't get all the way out easily. And so those are who can have sometimes humerus fractures or those clavicular fractures as well. So you're seeing, do I have symmetry? Do I have coordinated movements? And then am I hearing lung sounds on both sides? Am I hearing any aberrant heart sounds? So I should hear normal heart sounds. But what I will hear in this neonatal period is some interesting things. So things that I'm going to be looking for. First off, I want to see, do I have normal pulses? So where on a baby are you going to be checking for these pulses? Yep, so brachial is one of them. Where else? Femoral. Yep, so those are the two places that we're really going to be checking. I mean, if you're trying to find these little baby radial pulses, you can, but it's just a lot harder. And then sometimes when they're so chunky, it's really hard to find. So we're checking our pulses, brachial, those femoral pulses. If there is weak pulses, I start to think, do I have some sort of stenosis? Do I have some sort of outflow problem? Or do I have a volume problem? If I have bounding pulses, I know I had too much blood going out with each stroke volume from something like a patent ductus arteriosus, would be one of the things. Do I have any sort of these congenital heart diseases? So we will have a whole lecture on that in block 3, so we'll just leave it as that. Don't hear any kind of different murmurs. Anything that's pathologic or diastolic, not going to be normal. And then when I get down to my abdominal exam, do I have a gigantic liver showing that I have backflow and I can't actually move anything forward? So a couple things that we're going to be checking out for that. You also see that the ductus arteriosus closes over the first couple of days. So you might do an exam at hour of life 1 that sounds very different than hour of life 6 or hour of life 17. So it's a dynamic exam that's changing hour by hour. The reason also that we want to check those pulses both at the same time is to assess for coarctation of the aorta. I think I told you guys this when we did our lab last semester. We had like an 8-year-old that came in with an undiagnosed coarc because nobody at any point had checked to see if the femoral pulses and the brachial pulses were even. This is a super quick test. It takes about 3 seconds to determine, do I have equal upper and lower extremity pulses, to assess for those coarctation of the aorta. When I get down to my abdomen, I'm checking for a couple of things. Number one, the general shape of the abdomen. So I call it the toad belly. So babies should kind of have a big toad belly. I don't even know what else to call it. Big toad belly. Right? They shouldn't look like a little baby Hercules. They shouldn't have a big chest and nothing in the abdomen. When I have that, I get concerned that actually the abdominal contents did not form correctly, and the abdominal contents are in the chest, not in the abdomen. So that'll be later on in the surgery lecture. So that's what I'm looking for. When I'm talking about that toad belly, scaphoid would mean little baby Hercules, where you have the teeny tiny and everything's up in the chest. If I feel a hard mass, so it should feel, their big toad belly should kind of feel like sourdough bread, right? You should kind of be able, they're very squishy little guys. So you should be able to feel that there's nothing solid, hard, immovable mass. If so, your test of choice is going to be that ultrasound. And then I'm looking at the umbilical cord. I want to see how many vessels there are. How many should there be? There should be 3. How many veins? How many arteries? 2 of which one? 2 arteries and 1 vein. Correct. So that's an example of a 3-vessel cord right there. I can see 2 arteries, and then the one that is slightly bigger, the vein is going to be bigger. It was delivering blood to this child. So the 3 vessels is going to be normal. I need that because if I am in the neonatal ICU and I need to get a central line on this child, that is the perfect place, and we will use that often. The umbilicus, we will put a centralized catheter into the venous side, so the UVC, the umbilical venous catheter. If I do that, that is a centralized line. And so when you're taking a history for this child, you're thinking, have they had a central line? Do I need to check for blood pressures, or do they have a reason that they would have stenosis somewhere? So a centralized umbilical catheter can be one of those reasons. So you guys got it exactly, 2 arteries, 1 vein. What you will sometimes see is with an increase in genetic anomalies, you will have a 2-vessel cord where you will have only 1 artery and only 1 vein. It can be a normal finding that you see without any kind of pathology, but something to be aware of. So it is correlated with genetic anomalies. What you will see too, I don't know if any of you had younger siblings where you used to have to clean the cord, and that was part of every family, part of the baby's care is they cleaned the cord. We actively do nothing with the cord now. Do nothing. Have the families do nothing with it. Because what we want is the white blood cells and the bacteria that is on the skin to eat that away. So the fancy way I explain it to families, it's just a large scab at that point. So we want it to scab over and then be able to fall off. If it doesn't fall off, that's when I get concerned, why are these white blood cells not doing what they should be doing to make this where it can fall off? Yes, sir?
Because it falls off, how long does a UVC stay in before it's compromised?
UVC can stay in as long as it is put in right away. You can keep it in there until there's a reason to pull it out, or however often you would change the central line. What's really interesting is there are sometimes that a baby is born and we cut off the umbilical cord like that, and then later on we re-wet the umbilical cord to be able to use that so we don't have to do a subclavian line. So I've seen that up till about a week of life, which is a long time to do that. But we'll do that for several days and then we'll leave it in for a couple weeks. So, yeah. It's a really good central vessel. And then we avoid any kind of submersed baths, because that's an entry point into the abdominal cavity. So until the cord falls off and you know that you don't have that connection point, avoiding the submerged baths. Some variants that you will see. So this is a normal variant, one thing that we would take care of, but sometimes that we would see with this umbilical granuloma. So it's this little bit of that mucosa that is pulled out on the outside that did not kind of get all tucked in, and so it continues to have some serious drainage on there. So the way that parents will come in, they will say, I've changed their onesies, and there's always just this little spot that keeps draining. And so if you have this umbilical granuloma, it's super easy to take a silver nitrate stick and just cauterize that after you've determined that it's truly just this umbilical granuloma and that it's nothing else. So what are those other things that we could see? Well, was this actually a connection point, an aberrant connection to the bladder? This is a patent urachus, so it would be an embryologic remnant. So if you pushed on their abdomen, you would get urine that's coming out of the belly button. So that would be abnormal. Don't cauterize that. Do you have a Meckel's diverticulum? So when we talk about that in surgery, and I think you maybe had that in another class in GI, this could be a Meckel's. And so you would see that would be coming out. Or you can have another embryologic remnant called the vitelline duct, and that would have persistent and malodorous drainage. So it would look more like a purulent drainage. Very different than just small amounts of kind of a serous yellow drainage. If you determined I push on the belly, there's no purulent drainage, there's no urine, it's not bleeding like potentially like a Meckel's would, then you can cauterize the umbilical granuloma. It takes care of it right away. We get down to the hips. So what did we want to do for the hips? Do we do this with the diaper on or with the diaper off? Diaper off, perfect. So when babies are in mom, they're exposed to a lot of estrogen. Makes sense, right? They're inside mom. Mom has these higher amounts of estrogen. Estrogen makes everything a little bit more lax. So there's some laxity in some joints because of this estrogen. So every baby that is going to come out who's just been in that high estrogen environment is going to have a little bit of laxity in some of these joints. It's also due to some of the interuterine position that they have. They've been in a flexed position the whole time. So they'll have a little bit of this joint laxity. What we worry about is, did the whole hip joint, did the acetabulum form like it was supposed to? And if not, we have an entity called congenital hip dysplasia. And so what we worry about is, did the acetabulum form enough to be able to keep the ball and socket joints in place? So there's some risk factors that make that less likely. So things that are going to make this worse over time can lead to that acetabulum being flattened, to having that limitation in your motion, and that the baby's joint capsule is going to tighten a little bit. For whatever reason, it's thought to do with some of the positioning on the side of aorta and where the babies are positioned, that the left hip in firstborn females who are breech is the ones that typically will have this. So the left side slightly more. So breech is going to be your biggest thing, and that's because if the baby is head down, their legs, although still in a confined space, have a little bit more movement and they have a little bit more range of motion in that hip joint. It keeps it less in that tight position. If they are breech, they are more in a flexed and abducted position, and there's more pressure put on that hip. So breech positioning is your biggest risk factor for congenital hip dysplasia. Female infants, more of that estrogen exposure. The family history, they had it. Don't know why in first child. Maybe it's thought to do with some of the extra uterine constriction. This is the first time that the uterus is ever expanded like this. And then oligohydramnios. So if you don't have enough fluid, there's not enough for the baby to have that normal hip movement that you would expect. The other thing is that it can happen with some postnatal positioning. So another thing, much to pediatrician's chagrin, is when people turn their very, very, very new infant outward, so in an infant carrier, where the infant is facing the world, and we're talking in the first couple of weeks and months. So number one, visual stimulation. But number two, if they're in a forward-facing carrier, the hip is extended and abducted, as opposed to being flexed and abducted if it is towards the parent. Okay, so turn the babies inward for those first few months to avoid that. Your exam is going to be the Barlow and the Ortolani mode movements. And so for the first one, the Barlow movement, you're trying to see if you deduct the hip and you give it posterior pressure, is the acetabulum formed enough that it keeps the hip in that joint, or does it dislocate this hip joint? So if I put adduction, posterior pressure, does that hip clunk out of joint? Hopefully not. The clunk makes your stomach fall to the pit. Like truly, if you hear it clunk, you're just like, this is a bad day. If you adduct and you put pressure and there's a little bit of laxity or there's a little bit of a click, that's what we would expect. So it's truly, it sounds like a little click. Do you kind of feel this palpable click? Clunk's not okay. The Ortolani maneuver is the exact opposite. So now I am abducting the leg and I'm trying to give it anterior pressure so that if it went out of socket, does that external rotation, abduction, and then anterior movement put it back into joint. So that is that secondary movement that we're doing. If it relocates after it was dislocated, you'll get that clunk again. So typically, if you don't have a clunk with Barlow, you don't have a clunk with Ortolani. If you have a clunk with Barlow, you'll have a clunk with Ortolani. So did it dislocate and relocate? These are very specific tests, but they're not sensitive. So you might get a laxity, you might get some clicking, and you're like, is this normal? Is it not? Is it mild congenital hip dysplasia? I don't know. But if you get a clunk, very specific, that is congenital hip dysplasia until otherwise proven. That is going to be your ASAP referral to orthopedics. And when I call those referrals and I say, hey, I have a clunk on a Barlow and Ortolani, my question is, would you like to see them right now, or do you want to see them in like 20 minutes? Like, those are their options, right? This is an ASAP referral over to orthopedics. Things where I then say, who are the ones that I need to do an evaluation who I don't have a clunk on? Well, all of these kids, if there is something with a suspicious click, hey, I felt this click 100 times, and this one feels different. It's persistent. The child seems to be, there is some pain associated with it. All breech infants, if you were born breech, you're going to get evaluated because we already know you have that biggest risk factor for this. And then if you have 2+ of these risk factors without a click, so you were female, you have a family history, all your other siblings had this, you had oligo, I have the 3 strikes you're out rule is how I practice medicine. So if you got 3 of these things, I'm going to go ahead and do that ultrasound. So you were female, you were in a breech position, and you're the firstborn, I'm absolutely doing this. I guess just because they're breech, but multiple risk factors. If I have 3 things that go off in my provider brain, I go ahead and do the workup things. And what is the workup? Our treatment of our diagnostic of choice for all pediatrics, the hip ultrasound. So we do the same exact thing, right? At about 4 to 6 weeks, go ahead and get that ultrasound. So why do we do it at 4 to 6 weeks? Because in those first couple of weeks, we expect some of that laxity. We expect it to have a little bit of that mild movement, and I expect that to go away about that 4 to 6 weeks. So I don't need to do it right away. So if you're thinking, oh, I just saw them, they're an hour old and there's a hip click, I should get an ultrasound. Wait. I should get x-rays. Wait, that's if they're way older. I need to get an MRI. Nope. When you do any of those things, you wait 4 to 6 weeks, get a hip ultrasound for all breech, all suspicious things that make your provider flag go up, and 2 or more of these risk factors. Same words, if you like to study with an algorithm of how you're going to get there, it's going to be those things. Breech, multiple risk factors, and persistent or concerning physical movement. Your treatment is we need to get that hip in a stable position so that the acetabulum can grow around it. That's what's amazing about pediatrics, is if you give them time and the right environment, a lot of times their bodies will heal themselves. And so for this, orthopedics will get them in a Pavlik harness. That harness is going to keep them in a flexed, slightly abducted position that allows the acetabulum to grow around the hip. So it's the conservative treatment, especially if it's mild. If it's moderate, severe, a lot of times they do need a surgical option. Certainly, if that hip can't stay located into the hip joint, that's when you end up in a surgical option. If you have grandparents or great-grandparents that are still alive, a lot of them, back in the day, they used to do the triple diaper. And so they would do kind of the poor man's Pavlik harness, where they just did a whole bunch of diapers to keep the leg in that position. So, old school treatments there. On to the extremities. So some of the extremities, I will tell you an embarrassing story. From medical school, we had this baby that was delivered. I did the exam. The attending had already looked, so they knew. And I told them it was a completely normal exam. One of the things I had not done, I had not counted all of the digits. And this baby had an extra finger. So, stupid mistake to make, but literally now I go back and I'm 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 1, 2, 3, and I count them all because sometimes you miss them or sometimes they don't have them all. It can be supernumerary digits, they can be missing a digit, they can have syndactyly where the webbing embryologically was not removed in utero. So you can have all kinds of different forms. If you have this supernumerary digit, what am I worried that is in this supernumerary digit? A couple of things. Blood vessels, what else? Nerves, what else? Bone, yeah. So I worry that what's in there, and if I just said, I'm just going to rip that thing off, am I going to make an area where they have persistent problems with a nerve or bleeding or any kind of bone that's attached? So always, this would be the one time we're not going to necessarily ultrasound this, we're going to give an x-ray if it's on an extremity like this to see what kind of bony structure, and then sometimes they will do it a secondary one to see is there any kind of flow to that supernumerary digit. Sometimes hand will help us, sometimes plastics will help us, speech surgery, all kinds of things. But checking to make sure, are there 10 fingers, are there 10 toes? If not, an evaluation for it. Other things on the extremities, so the more movement that you have in utero and the longer you've been in utero, the more lines there are on your hands and feet. So if you ever looked at your hands and you thought to yourself, why are these lines there? This is fetal movement. So same for the feet. So more fetal movement, and the longer you've been in there, the more lines will be on your feet. So more preterm infant compared to a term or a post-term. Which gets us down to the foot. So when we look at most baby feet, most infants, when they're in utero, they're not only in that flex position, they kind of are in crisscross applesauce. And the feet are kind of tucked underneath each other. And that leads to a metatarsus adductus. So the feet have this kind of mid-foot deviation of the foot that if you moved it into a neutral position, the foot would move to neutral. But on its own, this passive placement, it's this medial deviation. A small amount of these kids can have increase in hip dysplasia, so it's one of the things we will look for. But when you're looking at the foot midline, you should see that the line from the mid-heel all the way up should bisect between toes 2 and 3. And in metatarsus adductus, it's a medial deviation, so you see it between toes 4, 5, or even further lateral. What will happen is as this child grows, and they start to put pressure on their legs and feet, and they start to walk, that will self-correct in the majority of cases. So like 90% of these will completely self-resolve. So you'll see patients that will come in all the time, my baby is walking with their toes in. And they're like 13 months old. And you're like, that's completely normal, we're good to go. Totally normal. Over time, they end up going from that medial deviation and it becomes more of lateral. We worry if it doesn't do that over the age of 2. So they come in and it's reassurance while they're crawling, while they're walking, learning to walk. If they have continued past the age of 2, that's when you start to think, I need an orthopedic referral. I say all of this and tell you about this stuff that when they're 2 years old, because if they come out and you can't move that foot into a neutral position, then they might have something of club foot, or the other name, talipes equinovarus. This is a whole problem with the leg, not just the foot. So if I tried to move this child's foot actively to a neutral position, that foot would not move. Okay, so that's going to be your difference. Does it move? And maybe it doesn't stay right away, but can I move it or can I not move it? This, so for club foot, this is going to be something that before they even leave, they have a referral with orthopedics because they are going to need some type of serial casting to move it, or they're going to need surgery to have the deformity manually done and then casted at that point. So, not a normal finding. Other one, normal finding. Continuing on down, we're going to check to make sure, do we have a male, do we have a female? Is there something ambiguous in between that needs a further workup? So for male, we should have 2 descended testicles. Sometimes you will see that they're retractile, so if it's really cold, or if they've just had a bath, the testicles might have to be brought down into the scrotum. The other thing we're looking at is to see the placement of the urethral meatus. So you can check that pretty easily sometimes by watching the stream of urine, right? It should go straight forward and kind of make that arc. If it goes that way, I start worrying, is there a hypospadias? Is there an epispadias? Did the urethral meatus actually go to the tip of the penis? So that's a thing to evaluate for. Do they have a hydrocele? Do they not only have testicles in the scrotum, do they have part of the bowel? So do they have a hernia? So things that you're evaluating for in that male. For females, you're looking at the external genitalia, and then also you would expect to see that there is going to be some hypertrophy. That is going to be from that maternal estrogen that they have. You don't expect to see the ambiguous genitalia ever. And then I want to make sure that they have an exit hole. So a patent anus is going to be very helpful, and that it is midline, not tracking somewhere else where they have an aberrant track out the vagina or out anywhere on the buttocks. You can see that. Or that they have no outflow track. I tell you that because I had a friend, one of my best friends from residency, she got assigned Japan, and she took off, and her very first delivery on call that night was a baby who did not have a patent anus. And so for that, you can't establish feeding. It's a surgical transfer, surgical right off the bat. So she got to learn how to transfer a baby in Japan very first night. So one of those things to think about. If I can't put anything into the inflow tract if I don't have an exit strategy. Our newborn back, so we're making sure, is it in alignment, or is there anything that's out of whack there? If I'm looking at, if I see a tuft of hair, think embryologically, did that form correctly? So if the ectoderm did not form correctly, that could be a sign that that tuft of hair on the outside, that something deeper did not form, and I actually have an interior spina bifida or myelin meninges. If I'm looking at the gluteal fold, is it midline also? If I open the gluteal fold, can I see the bottom, or do I worry that there is a tract and there is a fistula that is there? If I can't see the bottom, the skin does not close at the bottom, and I'm worried that there's a connection point between the spinal canal and the outside, so I'm going to get a spinal ultrasound for it. So if you have a deep gluteal cleft and you can't see the bottom, you have a gluteal pit, ultrasound. I'm telling you, if you don't know what the answer is, guess ultrasound every time. Spina bifida, so as I alluded to, if you see something that doesn't make sense on the back, this could be one of those things. The PANTS loves to ask this question about folate, about what trimester it's in, about the increased dose if they had a prior child with spina bifida. And the reason I think this is particularly interesting is there's a whole field of medicine now of fetal surgery. And so if they see that if they did this around the 20-week ultrasound, so they'll see, okay, this is the anatomy ultrasound, I see that there is spina bifida, a whole bunch of wild neurosurgeons, pediatric neurosurgeons, were like, I bet we could fix that. Super cool, in all your spare time if you want to watch a documentary, but it's called Twice Born, PBS documentary, about these neurosurgeons that said, hey, if we see this on the anatomy scan, we could fix this. And so they took these infants, they waited till they were 23, 24 weeks gestationally, so if they had to deliver, they could. And then they do the most controlled C-section in the world. So everything is super calm. They try not to get the uterus to contract. So if they can open up the uterus, they get the little baby's hand out, they put an IV into the 24-week-old neonate to give them pain medication. Then they pull the butt up. They fix the spina bifida. And then they put the baby back in, take the IV out, put baby back, sew up uterus, and mom continues to stay pregnant. Super, super cool. Did you guys start with Sergeant Reinkar's? So she let me tell this, but her sister was pregnant about this time last year, found out she had spina bifida, and we were able to get her over to Duke to have the fetal surgery done. The baby came out just fine. So pretty cool. Something that we do in real life, in real time. So, if you want a documentary to watch, it's super cool. Or I'm just really nerdy. So, one of the things is one of those questions you should be beat across the head with it, because it will be somewhere on your pants about folic acid. So, when you think about it from an embryologic standpoint, I know you guys don't have embryology, so I'm going to teach you what I can. The baby for a while is functionally like a 2D baby, like flat Stanley. And embryologically in that 4 to 6 week range, at the end of week 3, like day 21, baby kind of rolls around and becomes a 3D structure. Starts in the middle and basically zips up both sides. And the thing that allows each thing to kind of zip, work with me creatively here, zip is folate. And so if you do not have enough folate, you can start that process, but you can't finish the top or the bottom. And so if you can't finish the top, you end up with anencephaly. If you can't finish the bottom, you end up with spina bifida. So that's why you have this higher need for folate, particularly in the next pregnancies, because you've already demonstrated that you didn't have enough to finish that process with the neural tube. Neurosurgery, peds neurosurgery will be the ones that will help with either one of those. But folate for spina bifida, for the early gestation, the early first trimester, and you'll be good to go. Part of the neurologic exam that we are going to do is those primitive reflexes. So we'll go over those, but for any of you that have had babies or any of you that have been in a room and the baby will grab onto dad's finger and they're like, oh, he knows me. Don't brain it for dad. Like, let him have that moment. You don't have to be like, actually, that's a primitive reflex, and all babies have that with the grasp. Like, don't do that. Like, don't brain it for them. Let them have it, right? But those primitive ones are going to be the suck reflex, the Moro reflex, which is the startle reflex. So if you put a baby back, they should startle with their hands out. The grasp are the ones that we particularly assess for. There's a few other ones that if they persist or if they don't have those, you start thinking that something with the basal ganglia is not right. Usually disappear in about 4 to 6 months, and as their other reflexes start to kind of develop there. The ones I want you to know, so the Moro one, so Moro is going to be that startle one, so you hear both. So as the baby goes back, there's that sudden extension. Again, it's there at birth. Primitive reflex disappears by about 6 months. The grasp one, so you put something in the hand and they will wrap around it. Same for the foot. So if you put something on the toes will grab around like little monkey toes as well. The rooting reflex, so that is if you touch the corner of the mouth and move laterally, the head will turn to go wherever that direction is. So it's thought to be for breastfeeding or any kind of nipple that you move and they will root towards that food source. The trunk one, that's kind of interesting. It's thought to be with hand-eye coordination. So as one side flexes, the other side extends. I'll show you a picture of that one. The Babinski reflex, please know that one, that is just different for infants for everybody else. So if you got a positive Babinski and a newborn baby, you would think this is normal, this is good. As opposed to if you got that in an older adult, you think this is bad, not good. So difference there. And then the other one that I just think is kind of interesting because it is not one of your primitive reflexes, but is the parachute reflex. So the parachute reflex, I just think it would be hilarious if we walked around without this reflex, because it's the reflex of I'm tripping and falling, I'm going to put my hands out to save myself, right? So it's functionally how every foosh incident happens because of our parachute reflex, right? But if we didn't have it, and if a child didn't start developing this, every time they would fall, they would just fall flat on their face. So the idea of life without the parachute reflex is kind of amusing a little bit. But you see that one comes on around the 8 to 10 month mark, where that would be the earliest that a child is learning to walk, and they would need that reflex, and then it should never disappear. So one of those things that will change in time. But be aware of Moro, grasp, rooting particularly, and we'll take a couple of those. So that Moro, drop the head, be startled, grasp reflex, Babinski, and different for the infant versus older. The rooting, where they will move towards that. Sucking, where they will suck on the pacifier. It's one of those 5 S's that we talked about yesterday for soothing a child. There's an example of the fencing. So they are flexing one side and they are extending the other and looking towards the extended side. The reflex to say, oh my gosh, that is my own hand, that is my own foot, and I'm in control of that. So you can see that on both sides. What happens when these things go awry? So you can have sometimes where there are neurologic abnormalities. So if the baby is not having a good time coming out and they use forceps for delivery, so they're like giant salad tongs for labor, they go in and they clamp down and they pull baby out. A lot of times you can see areas where there's compression on the facial nerve. So facial nerve 7 is going to result in a facial nerve palsy, where they are only able to cry with one side of their face. Usually resolves over time, but mostly associated with forceps. So if you see something in a question on your pants that says, patient had a forceps delivery, patient had a vacuum delivery, patient had, and they give you a qualifier for a delivery, they're trying to tell you that that mode of delivery had something to do, and you should take that as a key for that particular case for why this baby would have this particular outcome. Before we start these ones, let's take a 10-minute break. We'll start at the top of the hour. We'll pick it back up with these leads. Talk about now what happens when something goes awry neurologically. So we're looking, we should see all these primitive reflexes, we should see limbs that are moving, we should see all that movement from the baby. What happens when we don't? So one of the things that can happen is, in addition to having a facial nerve palsy, you can see that if you've been in a birth, it's pretty traumatic, and there's a lot of pulling on the head and of that kind of upper neck portion. So one of the things that can happen is if it gets pulled too much and you end up with a brachial plexus injury. One of the injuries that has a classic pattern is this Erbs-Duchenne palsy. And that means that you have a higher injury at C5, C6. So you can see a couple of things with that. So your biceps reflex is absent, but your grasp reflex is still present in this baby. And so they call it the waiter's tip, because they don't have a bicep to either flex or supinate. So they can't supinate, they can't flex, but the grasp is there. So it ends up looking like a tip, like it's behind them and they can grasp and they're looking for a tip. So waiter's tip is from Erbs-Duchenne's. The reason that you see some respiratory involvement is because what innervates the diaphragm? What nerves? C3, 4, 5 keep the diaphragm alive, right? So if C5 is part of this and C5 has part of your phrenic nerve, you can see a baby who comes out with some respiratory distress, with the inability to supinate and flex that arm, and you know, that is an Erbs-Duchenne palsy, likely from that difficult and that stretching associated with a shoulder dystocia or a difficult birth where there's a lot of pulling on that neck. Good thing is infants heal themselves really well, so given enough time and some physical therapy, those infants do incredibly well. What's the exact opposite of that is if you have a lower brachial plexus injury. So now it's not high in that C5, C6 range, now it's lower in that C8 to T1. So now they have their they have their bicep reflex, so they can supinate and they can flex, but now they can't grasp. So it's the exact opposite. And so you have kind of a claw hand where it's up here and able to, again, do the biceps, but they can't grasp anything. So the clunky's claw is that part that we think of for its C8 and T1 stretching from, again, difficult deliveries. The other thing you will sometimes see is a ipsilateral, so that same side, Horner syndrome. So if you have that overactivation of the sympathetic nerves, or so you have overactivation of parasympathetic because your sympathetic nerves are injured. You can see that as well. So again, timed physical therapy does magic for this. The way I've always seen this, they talk about a difficult birth, and then they give you an example of either the hand or the claw, and they ask you where's the lesion. It's kind of the way I've seen that tested for boards. We've done the rest of the exam, now we're down to the skin. And so newborn skin is really weird. The best way I describe it is newborn skin is kind of the catch-all, and it has a lot of immunologic response and hormonal response to it. So you see things that happen on an infant's skin, and you're like, that's totally normal. If it happened on any one of you, I would say you should see a doctor. That's weird, right? You should go see someone. For an infant, totally normal, because they're very responsive immunologically and hormonally in their skin. It's very unique things that we see. So on that far left side, you can see some of those kind of newborn birthmarks, or nevus simplex. We'll talk specifically about those. You see the lanugo, or that kind of baby hair, and then you see that cheesy vernix. When we're looking at what vernix is, it's that kind of white chalky material that is on the outside of the baby from after they've been in utero. It's kind of this mix of cells and sebum and keratin and hair and all kinds of things mixed in there from in utero. The thought is that it has some sort of kind of protective, lubricating, immunologic component to it, but no one has a really good idea of why. Its true function unknown. Desquamation, this will happen to every infant. They have been in water for the last 9 months, or amniotic fluid. They come out and the top layer of their skin just kind of sheds off like a little snake. This is very disturbing to parents. If it, sometimes it will just happen over creases and parents won't really notice. Sometimes it literally looks like the infant is shedding their top layer of skin, and the parents will bring them in and they were like, this one's broken. I don't know what's happening, help us, right? And you can then look like a hero because you're like, this is desquamation. And I have the all life-saving treatment of lotion that will help this child, right? So that top layer of skin is gonna come off, baby doesn't care, the parents care, and you prescribe the life-saving lotion, and it's all good. Another one of those kind of extra 2x4 pieces that we will sometimes see are these epidermal inclusion cysts that are typically found on the nose, can be on other parts of the face as well. These little kind of look like whiteheads is the best description that you will see, but it's just an epidermal inclusion. It's called melia. You'll see this on the infant. And the reason that it's got a picture of a baby who is sleeping is because the baby does not care one iota that this is on their face. Parents will come in and say, what are these white marks? What are these white bumps? What do we do about it? And the infant's just like, sleep in there and you actively do nothing. It is a normal variant. It will go away on its own in that first month of life, just like the Bond's nodules and the Epstein curls in the mouth, as the baby realizes, I don't need these extra 2x4 pieces of keratin. Don't need them. Don't need these extra epithelial cells. Another common thing that we will see particularly here in Texas is melia rubra. So that is functionally a heat rash. So we're seeing this when an infant is really hot. The general rule of thumb is if a baby is too hot, too cold, if you're comfortable, the baby's comfortable. So in this room, the baby would be freezing, right? In some of the other offices, the baby would be hot, right? So if you're comfortable, baby's comfortable. What you will see is sometimes mom, grandma, whoever comes in, and infant, it's 117 degrees outside in July, and baby has 17 onesies on, right? And they're like, the baby's cold. You take it off, and the baby has these kind of maculopapular rash all over them that is not associated with the hair follicles. So that's a distinguishing factor, not associated with hair follicles. And once the baby is cooled off, it completely dissipates. It's melia rubra. The exact opposite of that is cutis marmorata. So that is another way to say they look mottled. So oftentimes that's from being cold. And so you will see they will call it a lacy or a lenticular pattern, where it looks kind of like everything is connected somehow, and that's that modeling that you'll see. If the baby is warmed up, so they're warm and it's still happening, or it's incredibly persistent over those first few months of life, then we start thinking, is something wrong with our metabolism, and is this a hypothyroid? Right? So there's another one of our, don't know what it is, let's guess thyroid, because it often has to do with a metabolism. So we start looking at that. If it's isolated, that's when you think more of a malformation or something to do truly with the capillaries underneath. Slate gray nevi or dermal melanocytosis used to be called Mongolian spots. That was the old name, so if you've ever heard that before, that was how it was known before. Do you remember what layer your melanocytes, are supposed to be in the skin? The basal layer of what? Of your epidermis, correct. So they're supposed to be there. That's where you're supposed to have your pigment cells, in that basal layer of the epidermis. Well, what happens here is your melanocytes get caught in that dermal layer underneath. So they didn't quite get to that layer in that basal part of the epidermis. And so they produce a bunch of pigment, but it looks different than when you have melanocytes that are in the epidermis. So those are where you see. Typically in darker skin, it has more melanocytes just in general. And so you'll typically see that in Black, Asian, East Indian babies, Native American babies, anyone who has more pigment. It will fade often over time, and this is really important that you document that first exam, because that very first exam, if they had that when they were born, you know they're born with it. As opposed to if somebody who doesn't see kids all the time and now they have what they call bruising on somewhere on their skin, they end up potentially with a whole workup for child abuse. So document those from the time they were born to make sure that it's distinguished from bruising. Another thing that we'll sometimes see on the skin is another way of saying birthmarks, or these cafe au lait macules. So they're macular, so they are flat. They're these hyperpigmented areas on the skin that you will see. One or two, totally normal, right? You'll talk to people and they're like, I have this birthmark, it's the shape of Maine, or whatever. People will have that all the time. What we start seeing is that when it is associated with more, so we start counting and we're like 1, 2, 3, 4, 5, 6, 7. The epidermis and the neurologic system form at the same time. And so embryologically. So if you start seeing that there's a whole bunch of things and a whole bunch of macules on this baby, are they at higher risk of a neurocutaneous disorder as well? We'll talk about that in block 3. But those are something to note, something to see. How many are there? What's the size of these on exam? Another form of those birthmarks we mentioned is the nevus simplex. You'll sometimes hear that called the salmon patch. And this is really, and I keep meaning to change this. Next to the word malformation, please write the word prominence. Because the capillary itself is not malformed. It's a prominence of how big this capillary is and how close to the surface it is relative to that size. And so that's the reason why when the baby comes out, this is the same child at 3 months and then at 3, almost 4 years old. So that it's super, super prominent in that newborn time period, not prominent at all. You can't even see it as the child grows because they kind of literally grow into those capillary vessels. So it's really not a malformation, it's truly more of a prominence. When you see them at a stork bite, that's what they're talking about when they're right here, in kind of the back of the neck or on that hairline. When you see it on the eyelids or kind of in between the forehead right here on the glabella, that's when you are calling them angel kisses. But nevus simplex, simplex sounds like simple, totally harmless. Contrast that to nevus flammeus. So if you think flames, flames can get out of control, and that can be much more serious than a simplex that is simple. So the nevus flammeus, the other term for it would be a port wine stain. So if you think about port wine, it is a very, very dark red wine. So it looks like that red wine was poured on the baby's face and left that stain on the face. That is a true malformation of the capillaries. Underneath the skin, the capillaries are malformed. We'll talk about this in block 3 as well, but it is really interesting because this is one of the things that if you have that deep capillary malformation underneath, there is also a neurocutaneous disorder much deeper on that ipsilateral side of the brain that has significant seizures. It's called Sturge-Weber syndrome. So anything from that face, the skin, the eye, and the deeper brain concerns that there's that underlying pathology. And they will end up needing dermatology, ophthalmology, and neurology to help with all of those. But contrasting that with what I need you to take away from today is nevus simplex, normal, totally safe. Nevus flammeus, associated with a lot of other things, not normal. I need to get someone involved. Erythema toxicum neonatorum. This one is funny to me because this is the most common thing you see about every single baby in the entire world, where you see this little erythematous base filled with eosinophils that pops up and then will completely go away. And we as pediatricians gave it the scariest name in the world, right? Totally normal newborn rash. That's how I call it to parents. I say, this is a normal newborn rash, right? So like, what's it called? And you're like, erythema toxicum neonatorum. Like, you have just scared the bejesus out of these new parents. So in the hospital or in the clinic, you'll hear it called ETOX, which sounds maybe a little bit better, but still weird. So I just call it a normal newborn rash. Right? So you'll see it come up and it will go away. It's totally self-resolving. So the scariest name, totally fine for newborn infants. Neonatal acne. So as they come out, the way I explain it to parents is they were just surrounded by all of those hormones and they kind of have to detox from the hormones from mom. And so they go through functionally like a reverse puberty for those first couple of weeks. We said that little females had hypertrophy of the genitalia. We'll say that they will sometimes have an estrogen withdrawal bleed that you can see. Similarly, they will have a period, or some will have a period of acne in those first few weeks of life as they're withdrawing from the hormones. Similar to how we have acne as we are starting to come into contact with these higher hormones. So it's kind of puberty in reverse. So in those first few weeks of life, they have some neonatal acne on the face that can be pretty pronounced, will go away on its own. The times where parents get very distraught over this is they're like, but we have newborn family pictures. We don't understand. You can do a course of self-limited, a mild topical steroid to help a little bit. Otherwise, you would say, maybe just reschedule your pictures for 2 weeks from now, and it'll be done. The answer, though, is self-limited, do nothing. But in life, you could do a topical steroid. Okay, so how long do we expect those primitive reflexes to hang around?
4 to 6.
Yep, 4 to 6 months. And what would persistent or asymmetric reflexes indicate to you? What is not right?
Neurological?
Neurological, yes. What parts? Like the basal ganglia. Something as a centralized issue in that basal ganglia, not normal. Okay, we still have 25 minutes. We're going to move on to number 2. If you downloaded it earlier, it was connected to the wrong one, so just make sure you have the updated When you guys got added to this card, just make sure you have the updated one for the second one. Also is transmitted slightly differently. So you can have it from the placenta, from mom. You can get it from transcervical during labor, or if mom has an ascending infection, you can have it before, during, or after the delivery. It's all associated with mom still. Look at your risk factor of term to preterm. So you are 6 times more likely to have infection as one of your causes of being preterm, or being preterm and having neonatal sepsis, just because you are so young. You don't have all of mom's antibodies, nor do you have a functioning and fully onboard immunologic system, and you are going to be in the hospital longer, so you have an increased risk of a nosocomial infection. So you kind of have a triple whammy there as a premature infant. Other risk factors are if mom is colonized with a group B strep infection, so it can be seen in the vaginal flora. We talked about yesterday, if that nidus of infection, if you had that rupture of your amniotic membranes that goes on for more than 24 hours, now we are in that prolonged rupture of membranes where the baby is exposed to the outside world. If mom is in labor and she has a fever, or you have known amnionitis, so baby is out and they are able to take the placenta and some amniotic fluid and say, this is infected. This is the source of that infection. You can see that as well. But the biggest takeaway is if you guys are in phase 2, or if you're working on the outside and you're on the labor deck at all, and you start to see fetal tachycardia on the rhythm and on the monitor. So you'll go over those with Dr. Love and what those monitors are going to look like in the strips. But the baby really can't tell you much. They're not going to say, hey, I don't feel good. Hey, I'm trying to die in here, right? So all the baby's response is going to do is to raise their heart rate. So tachycardia or any vital sign change in a baby should be taken very, very seriously, because that's really their only indication of, hey, something's wrong. So fetal tachycardia while in labor is an indication baby is in significant amount of distress. Our etiology for this neonatal type of sepsis. So I really just need you to know the first 2 in each column. Those are going to be your biggest highlights. So early onset sepsis means the first week of life. So if I had to guess, and if we're using empiric antibiotic coverage, I need to cover for that group B strep for the first week of life, and I need to cover for E. coli. Both of those things, because we were close to the anus from birth and we were in that vaginal flora. So those are those 2 things that I think about associated with birth particularly. Now I'm still a neonate, but I'm outside that first week. A little bit harder to blame it on birth as much in the birthing process. So I'm more likely to see this being an H. flu or a Staph aureus. So if you see something in a question stem where baby comes in and you're like, this looks like neonatal sepsis, and the question tells you, all the children in the house are colonized with MRSA or something like that. You know, they'll sometimes give you something that's super obvious like that, and you're like, oh, they're trying to tell me this is staph. This is a staph neonatal sepsis. The early onset, it's fast, a very fast onset. So it'll be like, baby was fine, and then an hour later they're not fine. So that's how quick you're talking about. Is we put them down, they fed at 2 p.m., we woke them up again at 4 p.m. and they wouldn't eat, they're not fine. Very, very fast onset. Any of those vital signs that you see are very concerning. So it's not just fever. If you see fever in an infant, you should pucker, especially in an under 28-day-old neonate. But the other one to think about is hypothermia. So sometimes, because they don't even have a functioning immune system fully yet, their body can't mount a febrile response. And so hypothermia is just as dangerous as hyperthermia to these kids. So just because you have a temperature that doesn't flag as high, something to look at in your vital signs as the provider. Another thing would be their tone. So if parents bring you a limp infant, something to be very concerned about, or if they're in respiratory distress. Your later onset sepsis. So outside of that 1 week, it's a little bit slower, a little bit more insidious onset. So maybe they haven't been feeding well for the last day or so. or they just haven't been acting like they've been acting for those first couple of weeks or days, or their tone is different, but it's really not truly limp or hypotonic. We'll talk more about some of the bilirubin associated with that. If you see some direct hyperbilirubinemia, then you start to think the liver, something's not right with the liver because I'm having trouble conjugating my bilirubin. This one's mostly associated then, or more likely associated with somewhere else. So meningitis, UTI, osteomyelitis, some other specific nidus of infection rather than the blood. So your laboratory evaluation, because the baby can't tell you, you're going to get a CBC. You're going to get 2 different blood cultures from 2 different places. So one from one arm, one from the other arm. So 2 different blood cultures to see if we can get that bug. You're going to get a urine with a urine culture. And then if you are a neonate, you are also going to get a lumbar puncture. The reason you need to get that multifactorial for those meningitis, but along with that CMP, you're going to see what's going on with the glucose. So we always worry about that neonatal glucose as well. That lumbar puncture is going to tell us a whole lot. Is there normal cell counts? Is there glucose? Is there protein? Is there bacteria that we need to be concerned about for meningitis? And the reason we specifically care is because that changes what antibiotics we're on and for how long. So without that, it's not a full workup. What I want you to see is that there is not imaging that's standard. So if you're thinking, well, I could ultrasound something, dear God, let me ultrasound something. There's nothing to ultrasound for this one, and there's not a standard chest x-ray that's done unless a family gives you indication that there's respiratory symptoms. So if they tell you there is a new cough, there is, they've been breathing funny, there's anything that gives you an indication of respiratory, then a chest x-ray is added, but it is not standardly as part of that urine, blood, and CSF for their workup. And then we want to make sure we get them on antibiotics ASAP. And so this is going to be a little bit different than your adult sepsis protocols because the infant doesn't have all of their functioning parts that are on board yet. So when you're starting empiric antibiotics, a lot of antibiotics that we use are clearing through the liver. Remember we just said the liver had its feet up for 9 months, really not doing anything while the placenta was taking over. And so we can't use something that's cleared by the liver right away in those first couple weeks. So we need to have something that's cleared by the kidneys and filtered out through the urine. And way back in your pharmacology days, remember gentamicin is filtered and cleared by the kidneys rather than the liver. So ampicillin, which is just IV amoxicillin. So IV amoxicillin, you have one of your penicillins, and gentamicin is going to cover your gram-negative. So your gram-positive and gram-negative coverage without affecting the liver. After 3 weeks, now we've said, oh, the liver is turned on, so we are able to use something that isn't ototoxic for the ears and has that same coverage and is now gone through the liver. So you switch to ampicillin and cefotaxime. So start those ones, know those ones. If they give you an indication of MRSA, or you need to cover for that, there's something in a question stem, or there's something in your history that says, hey, I think MRSA is involved, adding vancomycin. And then I think I will probably say this 100 times over the course, if there's any indication for HSV, acyclovir, IV acyclovir. Because neonatal HSV is really, really bad. If they have negative cultures and the baby is doing well after a sepsis rule out, after 48 to 72 hours, they can go home. If it is sepsis, it is in the blood, it is in the urine, they get 14 days of treatment. If it is meningitis, they end up with 21 days of IV antibiotic treatment. I don't need you to know this, but because GBS is one of the most common things that we see as the reason for sepsis, there's all kinds of tools and apps for you to use when you're on OB or if you're out in clinic and you're thinking, what do I need to do? Do I need to give this mom antibiotics? Do I need to do a workup for this baby? What do I need to do for this infant? It will run through a protocol for GBS specifically. So don't worry about this. I'm not going to ask you anything about it. Just be aware that it's out there for you. Okay, so that was if we have these bacteria. What about respiratory issues? We said most of the time, baby comes out, they haven't been breathing at all, so they are likely to have some sort of respiratory issues. This is aligning term versus your preterm infants. And I think it's interesting because a lot of the things that get term and preterm are the exact same. So you say, are they both likely to get sepsis or pneumonia? Well, yes, they both are. Are they both likely at the bottom to have a pneumothorax or congenital heart? Why, yes, they are. So what are the things that we're really trying to look at that is different? Well, there's an entity for your preterm infants, called respiratory distress syndrome. It's very specific to pretermers. And then for your term infants, meconium aspiration or transient tachypnea of the newborn are the ones we are going to focus on. So not that the other ones are not important, but if you're using this for testing purposes and you're thinking, well, what's the difference here? Well, one of them is specific for preterm and a couple of them are specific for your term infants. So I really can't walk any farther than that. Okay. If you haven't seen a baby, they're trying to do one of these signs that they will do is grunting. And so what grunting really is a sign of neonatal distress, where they are increasing their thoracic or inter-abdominal pressure and trying to keep open the alveoli. So they are kind of bearing down and having an elongated expiratory process to kind of keep that end expiratory pressure so that the alveoli do not collapse. And that is a sign of neonatal distress. So if a nurse comes and gets you or a tech and says, hey, the baby is grunting in this room, and you're like, well, must just be hungry, like that would be a sign of like, I need to go get up and look at that baby right now, because it's actually a sign of respiratory distress. The respiratory distress syndrome, another little history, used to be called hyaline membrane disease, and only associated with preterm infants, really. So, like, make sure you have that one highlighted. This is a preterm infant disease. If you think about back into medical history that I kind of nerd out about, this is what JFK and Jackie Kennedy's son that died had. He had hyaline membrane disease or respiratory distress syndrome. So had he been born today, he probably would have been just fine because we can correct this now. So what's going on? Well, at about 34 weeks of gestation, when mom's cortisol starts to go up, that raises fetal cortisol, and that is the sign to say to the type 2 pneumocytes in the lungs to say, hey, start producing surfactant. What does surfactant do?
Keep the lungs up there.
Around. Yep, I think you're right. It decreases the surface tension. So if you think about blowing up a balloon, then it's hard to get that balloon started, but then it's easy once it's kind of going. So it's that same type of thing. So the alveoli don't collapse. You have that surfactant that keeps that surface tension, decreases that surface tension. So if you are born before this 34-week period, you haven't gotten that signal to start making surfactant. So you don't have the ability to have a decrease in that surface tension. So every single breath, you are having to overcome that surface tension to keep your alveoli open and then collapse, open and collapse. And that is truly difficult and has some barotrauma for this infant. What it ends up looking like on x-ray is that you have diffuse atelectasis from those collapsed alveoli. And so that diffuse atelectasis that you see is what on chest x-ray will look like ground glass appearance. And so if you had a bunch of glass that you took and you smashed up everywhere and it just looked kind of fuzzy, that's what these x-rays look like. So they gotta have prematurity for this. You see it usually before that 34 weeks. They come out in distress and their chest x-ray looks like ground glass. You're like, ah, I know exactly what this is. And what do you think the treatment's gonna be? Surfactant. How are we going to give surfactant?
Orally?
Through the ET tube. Yep, from yesterday. Correct. So this is what this looks like, that ground glass appearance. So it kind of looks hazy everywhere. It just looks like glass was ground up. It's truly what that looks like. And it's diffuse atelectasis. That's what you're seeing. You're seeing, if you're looking at chest x-rays, you're seeing there's the tip of the ET tube right there. So you know this kid already got an ET tube. So if we know there's prior to birth, so we know mom's cortisol hasn't risen yet, but we're going to try to trick her body and trick the fetus into making it early That's why we will admit mom to give her steroids, because she's not making that increase of cortisol, but we can give her steroids that will increase the fetal cortisol to stimulate those type 2 pneumocytes. So if you can buy yourself that extra 48 hours, you can get some of that surfactant production in the infant. Again, after birth, you guys nailed it, ET tube and surfactant down it. What are some of the complications? Well, you can have a pneumothorax or some barotrauma, because you're having to get higher pressures to overcome that, that surface tension. You can also see where the infants are going to need higher amounts of oxygen when they come out. And that is then going to secondarily lead to that retinopathy of prematurity, because now we have trouble balancing out the oxygen versus the lung. Some associated with the patent ductus arteriosus, where they're not getting the signal to close that either. The ones that I really want you to know is the pneumothorax, or that barotrauma that you would see that. Dysplasia over time. Don't worry about the dysplasia. So really kind of, I need you, sorry, I need to discuss something about that. But pneumothorax is the biggest one. Yeah, associate that with retinopathy of prematurity in your mind. About apnea of prematurity. So infants, again, they will just, those poor guys with their hypoxia. So hypoxia leads to apnea. Yep. They don't have always that drive. So when we are defining apnea, we're saying it is a true pause in the cessation of the effort of breathing for 10 to 20 seconds. And really the NICU will count 20 seconds. And 20 seconds for an infant who's normally breathing every 1 to 2 seconds is a long 20 seconds. Okay? If you're watching a child not breathe for 20 seconds, that's a long time. But these kids will do this. So they will have an immature respiratory center of the brain that truly does not stimulate them to breathe. So that can be caused, one, is a central response in the brain. You can have that obstructive response, so potentially they don't have the musculature to move their head and their neck, so they can get obstructed in their little incubators, and you can see that as one of the reasons. Or a mixed type, and that's the most often thing that you'll see, because they will be immature and also some of a placement or a mucus plug. We definitely want to give oxygen, so you want to keep their oxygen high enough that they're not apneic, not so high that their eyes don't develop. We will literally give them stimulants, so we give IV caffeine. I know many of you in this room right now wish that you had an IV of caffeine.
Oh, yeah.
You're going to go to the neonatal ICU and we'll have that one. Making sure that we correct things that we can correct. So anemia, if they are anemic, we already are not going to have all of those building blocks to deliver the oxygen. So we want to make sure that we keep that as high as we need to. And it will usually correct itself. So this apnea of prematurity, as they get older, those responses in their brain develop, they will start to breathe on their own. Tracheomalacia is another one. So what does malacia mean? Yeah, softening. So if you have softening of this trachea, if you think about that, if you think my trachea was really soft, what would happen? Well, every time I would breathe, it would kind of collapse in on itself. And that's exactly what happens with these little guys. So if you have this softening of the trachea, they breathe in, it's all open, they breathe out, and it collapses on itself. And so when it collapses like that, it ends up making kind of a whistling or a wheezing noise. That can be worse if they're breathing faster. So they're crying. There's crying. If you think, how long do I spend in exhalation versus inhalation? Spend a lot more time in exhalation. I breathe in, and then I breathe out, I'm crying. It's a long expiratory time, so it's a longer time that parents are hearing that wheezing sound or that kind of whistling sound. If they're sick and there's inflammation, so if they have a URI, it's going to have even increased sound of that. The more severe it is, if there's airway compromise or severe respiratory compromise, or they can't even breathe enough while they're eating, ENT will sometimes have to go in and stent this open or have a tracheostomy to be able to have this infant breathe. So this would be incredibly, incredibly severe. You will see this oftentimes though as a very mild form, where on expiratory breathing, you hear the slight wheezing sound. So that is most of the time what you're actually going to see. Meconium aspiration, I think of this as the term respiratory distress syndrome. The reason I say that is because it happens only really typically in term babies. And it happens when typically they're post-term. So one of the signs when a baby is ready to be delivered is it says, I'm out of here, and it will have its first baby poop or meconium while still in mom. And so you will see they will break the bag of water, they will break the amniotic sac, and meconium will come out. You're worried about a meconium delivery. And the reason that we hear about that is meconium goes in if it is aspirated by the baby, and it will denature the surfactant they just made. So they made the surfactant at 34 weeks, we're going to decrease the surface temperature, and then they stayed in there so long that they pooped, aspirated it, and denatured their surfactant. So now we have this patchy part of atelectasis. And so they come out and they look like they're in respiratory distress. They look like they have this pneumonia, they look like they're having pneumothoraxes. Potentially they're hard to resuscitate, and on chest x-ray you see coarse and patchy areas of that ground glass look. It's because not everywhere has the atelectasis, just where it got aspirated down into. So that's why you call it the term respiratory distress syndrome, because it's happening in these term babies, but the mechanism still has to do with surfactant. Of course, patchy infiltrates, again, causes that atelectasis. These babies, though, get very, very, very sick. They end up with sometimes needing to be on a vent, sometimes needing a significant amount of resuscitation and even ECMO. Contrast this versus transient tachypnea of the newborn. So we said this is a post-term baby, they aspirated their meconium, very, very, very sick infants. Contrast that to transient tachypnea of the newborn. So transient, all the words, right? Transient, meaning it's very brief. Tachypnea, meaning they're breathing more than how many times a minute? What was the upper limit of normal? 60, right? So they're tachypnic above 60 a minute, and it's just a little while. Okay, so all those words. That makes it sound really safe, and it really is. So what happens in utero while labor starts? The best way to think of it is as labor is starting, they are getting the signals to start moving all of that fluid out of the lungs in preparation for that first breath. Then they go through a vaginal birth where they functionally get kind of squeezed out as they go through mom, and all of that fluid kind of moves out. So if two things happen, number one, if they have a very, very fast delivery where not all of that fluid had time to move out, or if we have a C-section where they were just totally fine in there and we just rip them out and cut them out, they have not had the time to get rid of all of that fluid out of their lungs. And so for a 24 to 48 hours, you see in the fissures of all of the lungs, you still see that there is some fluid there. And they have tachypnea. So they're just breathing really fast. They're just trying to get all of that fluid out of the fissures. So there is some tachypnea, some retractions, some little bit of hypoxia, but it's more of the fact that they're breathing so fast that they can't feed, and then we worry about their glucose. So while they're trying to breathe and get all of that fluid out of their lungs, we're having to support them with a little bit of oxygen and a little bit of glucose. So they still end up in the ICU, but just for a little bit because it's transient, it's the tachypnea. So that one's more of a safe thing. We see it often in precipitous deliveries and C-section deliveries. We already covered this yesterday with that neonatal hypoglycemia. So what's going on with that? So mom is diabetic. Her blood sugar is high or low? What does it do to the baby's insulin? High or low?
High.
And then birth happens. Does their insulin stay high or go low?
Stays high.
Stays high. So what does that do to their glucose?
Down.
Drops it. That's exactly what happens. So things that we see, it's less than 60. So their blood sugar is, it should be above 60. So when we see it, it's less than 60. We see it in those large infants because they're infant of a diabetic mother. We also see this sometimes in small infants. So your really small ones, really big ones, and then IDM is infant of a diabetic mother. That's exactly, you guys got it. Often the signs are very subtle. So you can see some infants that lose some of their tone. You think about how do you feel when you're hypoglycemic and you're just kind of like, I don't feel good. Kind of what the infant feels like as well. So a little bit of hypertonia, a little bit of hypothermia. They don't really want to eat, even though that would solve the problem. And sometimes they will quit breathing on you. So if it gets low enough, they end up with a hypoglycemic seizure. What I don't need you, do not memorize this. Please do not memorize it at all. This is just an example of a glucose protocol that the newborn nurseries will have. So they'll say, oh, we have an infant of a diabetic mother. We have a baby that's SGA, LGA. So we did all those growth things from that very first exam. We need to put them on this protocol that at routine intervals, every couple of hours, checks to make sure the glucose is not low and does something about it if it is. Necrotizing enterocolitis is another thing that will happen. So it will be abbreviated NEC, is how you will hear it. So that one is pretty scary sounding. Necrotizing enterocolitis. So inside the colon, we have necrotic flesh happening. And that's exactly what is going on. So the baby's gut, if they were premature, was not ready for all of these feedings. So this immature gut is trying to handle the digestion of these proteins and carbohydrates that it wasn't quite ready to do yet. And because of that, you don't really see it as much in these full-term infants. You see it in these premature infants. One of the things will help is if we can give human milk as opposed to formula, and if we give probiotics, those will be helpful as well. So what happens with these infants is their gut not only can't digest it, the gut itself will start to die. And so you will get dead intestinal mucosa that will then start to be necrotic and spread. And so once that starts, it will spread very, very quickly. So the babies will start to have abdominal distension because the bacteria are releasing some air. And so they're starting to get distended from that. They're not taking their feeds well because it can't move forward or digest any farther. You'll see something called gastric residuals. So if a nurse is checking at the end of feeding to see how much is still left in the gut, sometimes the entire feed will come right back up. That's what a gastric residual is. Sometimes they'll start throwing up or having bloody diarrhea because that necrotic tissue is sloughing off. If you get to these later signs, they are septic and they are trying to die on you, where they have DIC, very, very bad. Or a blue abdomen, if you ever see a blue abdomen in a baby with some of these signs, very, very sick baby with that. Your radiograph, when you're looking at that, it is going to have that air that you're seeing. So it's true air that has gotten inside from the bacteria into your intestinal walls. That's called pneumocystis intestinalis. And that's a classic sign that you would be seeing for necrotizing enterocolitis in that preterm infant. What do I think that maybe it could be? Well, I think maybe this could be sepsis. I think maybe that they have a volvulus where the intestine's twisted on itself. Have they had some sort of perforation in the bowel? Do they have a Hirschsprung's disease? We'll talk about that in block 3. So what do I need to do? I need to stop putting things in the gut, not use the gut, stop any kind of enteral feedings. I'm going to switch to TPN, or total parental nutrition. They're going to get all of their nutrition via IV. I'm going to decompress the abdomen, so I'm going to take as much air out as I can, and then fluid resuscitate them while I get them ready for potential surgery so that we can cut out that necrotic bowel. So the biggest part that I want you to take away from that is not to get in the ins and outs of NEC, because many of you will probably not be in the neonatal ICU, but in a preterm infant who's having difficulty with feeding and starts to have vital sign and abdominal abnormalities, that should be on the different. That's the big takeaway. Just a little bit more. I'm trying to get right to hyperbilirubinemia. So anemia. This makes sense. One of the things, every single infant is going to come out with a higher hemoglobin, and it will slowly decline in every infant till they're about 3 to 6 months old. It's really nice then, because around the 4 to 6 month mark, we start feeding with food that has iron, or iron fortified cereals for these babies. So we kind of hit that time is perfect. But in the interim, some of these children will have some pallor. Makes sense. They don't have red blood cells. They can come out lethargic or hypotonic, poor feeding. Their O2 can be a little bit lower, so that should make sense. And if it gets so low, these are infants that we do want to do transfusions for. Why are we talking about these with neonates? This doesn't seem like a common thing. Well, the common things that we see this are when you have ABO incompatibility. So mom and baby are different, and mom's antibodies go and attack baby's red blood cells and kind of blow them up. So that would be thing 1. We also see that when we had that RH incompatibility that we said yesterday, so that second pregnancy, if you're sensitized to that. And there's a whole bunch of other antigens. I'm not going to test you on those other antigens, but just know that if you have a baby that you can't explain what's going on, there's a whole bunch of other antigens that cause it. These are just the most common ones. We could have lost a lot of blood and be anemic from birth. What if we had a cord rupture? What if we had a maternal hemorrhage? What if we had that placenta abruption we talked about yesterday? You can see all of those things. Or iatrogenic. They've been in the NICU so long that we've drawn so much blood from them that we made them anemic as healthcare providers. Anemia of prematurity is going to be even worse. So anything that's going to be bad for a term infant is going to be worse for those ones. So under those 32 weeks, they not only have that decline like all babies, but it happens earlier and it happens more severely. It's also made worse because we're getting labs every single day in the ICU. So they are the ones that get hit with those iatrogenic ones. If you think about it, we just take blood from an adult, no problem. But for infants, there's truly a chart that says on this day you can only take this much. So this is sometimes where you have to decide, do I want this lab or this lab, because I can only have this much blood today. So a little bit different for peds than that. And that takes us to hyperbilirubinemia. So we get to start fresh tomorrow with one of my favorite topics, all of peds. Questions, comments, concerns, anxieties, frustrations, projections, griefs, miscellaneous toxicities. Cool. Have fun in med ethics.